The last cause of neonatal anemia and the rarest among them is bone marrow failure. When the bone marrow stops to produce RBCs, the neonate will have anemia. It can happen due to genetic bone marrow failure, like Fanconi anemia, or secondary to an intrauterine infection, as parvovirus infection, or drugs, for example, chloramphenicol. To reach for the cause of neonatal anemia, we have to carefully consider the clinical picture, as history of twin or cord prolapse. We have to know the blood group for the baby and the mother as regard the ABO blood grouping and RH blood grouping, because if the mother have an RH negative blood group and her baby, for example, have RH positive blood group, this might point to RH disease of the newborn. Next, we have to ask for Clay-Howard test, which we will discuss in the next slide. Do a complete blood count or CBC and check for the blood under microscope, which we call it blood film, to diagnose any anemia which have a specific form like congenital spherocytosis, where the RBCs will be very rounded, or elliptocytosis, where the RBCs will be elongated. We have to check for the reticulocytic count or retex and bilirubin, because in all cases of hemolysis, the baby will have high reticulocytic count and the bilirubin will be elevated, while in babies with bone marrow failure, we will have a low or subnormal reticulocytic count. Do a C-reactive protein or CRP, which will diagnose sepsis, which is a cause of neonatal anemia. And lastly, we ask for Coombs test, which will diagnose autoimmune hemolytic anemias. This slide shows a positive Clay-Howard test. We do this test to diagnose feto-maternal transfusion, or simply bleeding from the neonate to his mother. Because neonatal RBCs contain hemoglobin F, while the adult or his mother RBCs contain hemoglobin a drop blood from the mother under the microscope with addition of 1% sodium hydroxide will lead to denaturation or hemolysis of the adult RBCs of the mother, while the fetal RBCs will still be intact. In this slide, we still can see a normal red RBCs, which is probably from fetal origin, compared to ghost RBCs all over the slide from his mother. So the cause of anemia here is feto-maternal transfusion. For babies with neonatal anemia, if the anemia is severe, we can give blood transfusion in the form of 10 ml per kilo over 3 hours. In most of the cases, supplementing the neonate with folic acid and iron is sufficient. In case of RH disease and ABO, or hemolytic disease of the newborn, this baby might need exchange transfusion, especially if he is jaundiced. The second group of problem that we are discussing in this presentation is neonatal bleeding. The neonate might be bleeding externally in the form of hemoptysis, hematemesis, bleeding per rectum, or bleeding from the nose like epistaxis, or he or she might be bleeding internally, like intracranial hemorrhage, or around fractured femur within the tissues of the thigh. Or the bleeding might be under the skin. If the bleeding is small spots, we call it purpura, and if it is big patches, we call it ecchymosis. This slide shows CT scan of a neonate who have sustained intraventricular hemorrhage right here. Bleeding in neonate might be due to a coagulation defect or a disease severe enough in the liver, which is the site of synthesis of most of the coagulation products. Usually the neonate will have a normal platelet count and normal bleeding time, but the prothrombin time or PT and partial thromboplastin time or PTT will be prolonged. The clotting time usually is prolonged. The second group of causes is platelet defect. In this group of babies, the platelet count will be low and the bleeding time will be prolonged, while the PT and PTT will usually be normal and the clotting time will be normal as well. In diseases such as disseminated intravascular coagulopathy or DIC, both elements will be affected. So the neonate will have a low platelet count together with coagulation defect. Discussing neonates with bleeding, as we said in the previous slide, we might have a problem in the coagulation or a problem in platelet. If it is a problem in coagulation, we have to check for how the baby looks. We call it a well baby. And a well baby is a baby who is active, crying, and feeding well. The causes will include hemorrhagic disease of the newborn, which is the commonest cause of bleeding in neonate, or hemophilia, whether it is A, B, or C. And as we said before, in these babies, the platelet count will be normal, while the PT and or PTT will be prolonged. Now, one of the commonest causes of bleeding in neonate in general, and it's a cause of bleeding in a well neonate due to coagulation defect as well. This common disease will present with spontaneous bleeding between day 2 to day 6 of life, and the etiology usually is vitamin K deficiency, because the intestine of the neonate does not have intestinal flora and the liver is quite immature with decreased production of factor 2, 7, 9, and 10. The clinical picture will include bleeding from nose, umbilicus, GIT, or intracranial. And usually we prevent this disease by giving all neonate 1 milligram of vitamin K or conazole intramuscularly at birth.